Welcome back to our fourth and final panel of the spring workshop of the National Academies Roundtable on Population Health Improvement. This workshop is entitled Healthcare Expenditures, Costs, Lessons, and Opportunities. My name is Dora Hughes, and I am a physician and policy researcher at the Milken Institute School of Public Health and School of Medicine at the George Washington University in Washington, D.C. My work focuses on supporting and scaling accountable communities for health, which are multi-sector partnerships seeking to align public health, healthcare, and social services to address both individual and community health needs and to advance equity. It is my pleasure to moderate this panel today. Before we dive in, as a reminder, in our first workshop panel, we heard perspectives on the challenge, the opportunity costs, and equity issues. In the second panel, we heard about innovations to bend the spending curve. Earlier today, in the third and our last panel, we heard from experts about how we can frame and shift the narrative. And now for this fourth panel and final panel, we are going to focus on the research priorities that have or could inform our efforts to tackle healthcare expenditures. We will focus on what we know and what we need to know to better inform how we invest in health, not just healthcare, for better and more equitable outcomes, including priority setting and resource allocation across different sectors, on marshaling the evidence for and investing in prevention and community health improvement, as well as, importantly, implications across all of these areas for both policy and practice. I am delighted to introduce our six panelists, although for sake of time, I'm only going to share their title and institution. Please refer to the attendee packet for their complete bio sketches. Joining us today, we have Sherry Gleave, Dean and Professor of Public Service at the Wagner School of Public Service at New York University. We have Meena Seshimani, Vice President of Clinical Care Transformation at MedStar Health. Simon Walker, Senior Research Fellow at the Center for Health Economics at the University of York in the United Kingdom. We have Rachel Thornton, Associate Professor, Division of General Pediatrics and Adolescent Medicine, and Associate Director for Policy at the Johns Hopkins University Center for Health Equity. We have Jacob William Faber, who's an Associate Professor of Sociology and Public Service, also at New York University. And last but not least, we have Chapin White, Deputy Director of the Health Analysis Division at the Congressional Budget Office. Each of our panelists will share highlights from their research, and then we will dive a bit deeper with follow-up questions. If you have a question, please enter them into the question and answer field below the webcast window, and we will certainly try to answer as many of them as possible as time permits at the end of our panel. So with that, we'll go ahead and get started. Sherry, I'm going to turn the virtual mic over to you to kick us off.
Okay, thank you very much, Dora. So Dora asked me to talk a little bit about some research that we've done lately, and I think I'm going to talk about two aspects of the research we've been doing. One is a project Austin Fracht, Ashish Jha, and I did, trying to unpack those well-known decompositions of the drivers of health. For example, the decomposition of causes of death into, for example, behaviors, social circumstances, environment, genetics, medical care, and typically those kinds of decompositions, which I think we all in public health have often quoted, show very large contributions of social circumstances and behavior relative to medical care. So I want to talk a little bit about that, and then about sort of adjacent work to that through our WJF-funded Policies for Action Hub on non-health policies and their impacts on outcomes in the Medicaid population. So let me start with the work that Austin and Ashish and I did, which has really led me to sort of reconsider how we might be thinking about the contributions of different parts of our ecosystem into health and how we want to evaluate them. So the first thing that we learned is that actually these decompositions are not very meaningful. They can be useful. They can help us in comparing places in a cross-section or in making comparisons sort of across cities, but they don't provide a great guide to policy. And fundamentally the problem is, and we're not the first people to point it out, is that most bad outcomes that we see are a consequence of the interaction of many factors. And let me just illustrate that. For example, consider somebody who dies of HIV in the US in 2020. What caused that death? Well, the outcome is a consequence of a behavior, say sharing needles or unsafe sex, of circumstances, say not having regular access to PrEP therapy because of housing conditions, genetics, say being one of the people who's more susceptible to HIV infection, and medical care, perhaps insufficient response or access to antiretroviral therapy. As people have pointed out, these decompositions simply don't account for the interaction effects between behavior, environment, genetics, and so on, which are clearly not mutually exclusive. And as a simple mathematical point, the existence of these interactions really throws off the whole effort at decomposition. The second point that's related to that is that the relative contributions of different pieces varies a lot over time. If you were actually doing the same decomposition before the antiretroviral therapies existed, before they had been invented, the decomposition would load quite differently in terms of what caused that death to occur. This example, I think, really illustrates some of the important challenges in how we move forward thinking about not only medical but social determinants. When we attribute an outcome to medical care as its determinant, we only do it if there actually was an intervention that we knew about that worked to address the problem. That is, before there was an effective treatment for HIV, we simply didn't attribute any mortality from HIV to medical care. But we don't take that approach with behavioral or environmental causes. We argue, for example, that diet and exercise contribute to obesity and related mortality, and surely they do, but we do that without knowing whether we have effective treatments or interventions that address diet and exercise in ways that effectively reduce obesity and mortality. We still attribute it to diet and to environmental and behavioral causes, even if we have no intervention that would address that. So we should really, I think, be applying very similar standards as we think about where to intervene in the medical space and in the behavioral and social determinant space. We should be asking questions like, what interventions work and for whom, and how well, and at what cost? How do they work with communities, and so on? And one way we need to do this is that we should be focused on the effects of potential interventions in social determinants, interventions in behaviors, interventions in environment on health outcomes, not simply on associations between social determinants and health outcomes. We should use the same approach as we do for clinical care. And right now, the evidence base for interventions is very limited, and how these interventions work is very context specific. So even where we have snippets of evidence, it just isn't robust enough. On the other hand, in sort of favoring social and behavioral interventions, we also need to use a different standard than we customarily do in the health space when we judge those interventions. In many cases, we are still judging behavioral and social interventions aimed at health outcomes using a cost-saving standard, like, will improving housing save money for the healthcare system? But that is not the standard we would use for a new medical intervention. There we would use a cost-effectiveness standard or even a cost-benefit standard. We really should do the same here. Which is the more cost-effective approach to improving asthma? More aggressive distribution of inhalers at this point, or rehabilitating housing? Rehabilitating housing might cost more money, but it also might generate greater benefits. And that sort of leads to the final aspect of this comparison, which is the best thing about interventions around the social determinants of health, unlike clinical interventions, is that they do a lot more than improve health. If using an inhaler only improves asthma, if the inhaler doesn't improve your asthma, it's useless. But better housing is good even if it doesn't improve asthma, and we shouldn't fail to make that case as well. So actually this literature trying to look at interventions shows some very clear winners. I think probably the one where the evidence is the most robust is about transferring income to very low income families, especially those with significant health risks. We have a nice paper on that looking at low birth weight infants, but there's a lot of research that shows that cash transfers improve longevity, nutrition, mental health, maternal mental health, and so on. And there we know that even if it doesn't improve health, it still does an awful lot of good for families. So I think these two strands of literature together provide us a way forward. Let me stop there. I can't hear you. Dora, I can't hear you.
Mina, do you want to go next?
Sure, thank you. And I'll build off of some of what Sherry spoke to about, the importance not just of identifying the various factors that affect a person's health or a community's health, but also really taking into consideration where we do have interventions and how we're going to assess those interventions. From my role, so I lead clinical care transformation at MedStar Health, which is a 10-hospital, 300 outpatient center health system in the DC area. And a lot of what my teams do is really creating connection across our distributed, care delivery network between our hospitals, our ambulatory sites, the community, post-acute care, home health, so that we can provide more holistic, patient-centered care with a vision of providing the right care to the right person in the right time and place by the right type of provider who has the right tools to do so. And I think taking this approach, it builds off of what Sherry spoke to, where if we do identify determinants, both clinical and social, that are impacting somebody's health, what steps can we take to intervene? And a lot of the research that we are engaged in is being part of this continuous improvement mindset, where we try to use data to identify where there are gaps. So if people are not where we would like for them to be in terms of their health, what are some root causes to that? So doing analyses as much as possible to be able to identify gaps, and then from there, figure out what are some root causes for that. And then doing an intervention with an eye towards assessing whether that intervention had the type of impact that we were hoping. And with our interventions, we oftentimes look at that impact both in terms of processes and in terms of outcomes. So from the process side, things like, were referrals made to various programs? Did people follow through on those referrals? What were the experiences with those care touches? Who were the people who touched the patient or the community? And then looking at various outcomes. I think there's been a lot of focus on the reduction in utilization and the reduction in cost. But to echo some of what Sherry said, being able to think more broadly than that, to consider what impacts are on an overall community, what are health outcomes and also cost and utilization outcomes, so that we are taking a fuller scope to what we're doing. And I think that leads into what is one of the biggest challenges with this kind of research that we experience on the provider side, and that I think Sherry alluded to, around programs have traditionally been assessed in a particular silo in which they are viewed where there is data. So, take the example of the electronic medical record. I mean, there are Z codes that you can put in for social determinants. It's really plus or minus whether people are using them, how effectively they're being used. And then beyond that, when you have an intervention, like, for example, we have a care transitions program that identifies people with social needs, makes referrals to community-based organizations, helps with pharmacy, et cetera. How are you able to capture if, say, a referral was followed through with the community-based organization? And what was the impact of that, not just for the patient, but oftentimes for the patient's family? So there are many aspects to a lot of the interventions that are done that present some data challenges in terms of breaking down silos in the data, not just clinical, because even within clinical, you move from an electronic medical record to claims data, enables you to expand beyond what one health system sees of somebody's healthcare usage to what that person sees across all the ways that they touch, but even to expand beyond the healthcare side of it to some of the social settings, I think is a real area that needs to have investment and work if we really want to be able to assess the ultimate impact of these various interventions that we are doing.
Thank you. Thank you, Mina. And with that, Simon, do you want to continue? I know you've certainly doing some work with this. How do we make decisions where the outcomes may benefit multiple sectors?
Yeah, thanks very much for that, Dora, and for the interesting talks previously. So yeah, one of my main research areas is around how to use economic evaluation to inform multiple heterogeneous decision makers, all of whom have particularly, have different goals, different aims, different things they're trying to achieve. So economic evaluation can play a crucial role in informing decision making by providing evidence on the benefits, costs, and opportunity costs of alternative policies. And this allows us to assess whether policies represent value for money, i.e. do their benefits exceed their opportunity costs. But that's at the heart of economic evaluation are two sort of broad sets of different types of questions. The first of those are questions based on values or normative principles, and the second are based on factual assessments. And so value assessments are actually really important here, because the value assessments set out what we care about. What are the outcomes of interest? What are the relative values of those different outcomes? Do we value those outcomes more for some individuals than for others, for example, because of equity concerns? That's one set which economic evaluation needs to consider. And then we've got the factual assessments, which is more what the analysts are involved in, which is assessing, given what is the impact of a policy on those outcomes of interests, in terms of the benefits and, crucially, also the opportunity costs. So for those value questions, it would be great if we were able to call upon, some universally agreed social welfare function, which defines exactly what society cares about in terms of the outcomes of interest and the relative values of those outcomes. Unfortunately, then we could use that to inform our assessments and also our decision making. But unfortunately, there's no universally accepted function. There's many possibly contested possibilities. And it's not really clear how useful it is to use those for decision making, particularly given the sort of institutional arrangements that we see in many societies. So with regards to those institutional arrangements, societies typically structure themselves in such a way that resource allocation decisions are split across different decision makers, with each of those decision makers given their own area of responsibility defined by the budget they receive and the goals to which they're held to account. So, for example, within the UK, we've got a Ministry of Health who are responsible for improving population health. We've got the Ministry of Criminal Justice who are responsible for maintaining law and order. We have a Ministry of Social Welfare for making sure that no one is living within poverty. And it's really important as an analyst when we're considering policies that we think about evaluating policies from those perspectives, because those are the people we're trying to inform. So the analyst should be able to provide the evidence required to inform each of those decision makers, given their particular responsibilities and their silos. And then in terms of both the impact of the policies on the outcome and the direct effects on opportunity costs of those decision makers of interest. So, for example, I recently worked on an evaluation of an alcohol misuse intervention within criminal offenders in the UK. And this was an intervention which was funded by healthcare and had impacts on the health of the participants, but also clearly had criminal justice impacts. So it potentially reduced recidivism and reoffending by those individuals, and which also subsequently had further impacts on health by reducing future victims of crime and injuries to those victims of crime. And we need to think about what the goals of a decision maker we were trying to inform in that case. So we've got a healthcare decision maker who was trying to improve health, and the criminal justice decision maker who's trying to reduce crimes. And by providing evidence on the direct impact on health and the opportunity cost on health, we can look at the values from the decision maker, the healthcare decision maker. And similarly, by providing evidence on impact on reoffending and the opportunity cost on reoffending, we can provide evidence to the base which the criminal justice decision maker is interested in. If both those decision makers are winners, we see an improvement in health and a reduction in crime, it's quite an easy decision. And we should go about implementing the policy. However, in many cases, there'll be winners and losers. But these types of analysis, where we show the costs and benefits in the different sectors, can facilitate discussions between those decision makers about whether and possible potential policy responses, such as transfer payments, co-financing, to ensure whether we have winners and to ensure that both are winners and losers. So that sort of touches on one of the first issues. I just also want to briefly touch on a couple of the factual issues. So the first is, it's really important that we actually understand the effects of a policy, and that often means moving beyond that the decision maker's silo, their area of responsibility. So that criminal justice policy I touched upon before impacted the health, even if you're only interested in health, if you took a really narrow perspective, you'd fail to recognise that by reducing offending within the criminal justice sector, we were also impacting health of those victims. And it's really important, even from that narrow perspective of health, to figure how these policies interact through the system. I also, secondly, just wanted to highlight the crucial role of opportunity cost. It's not just necessary to estimate the direct impacts of a policy. It's essential that we estimate the opportunity costs, what outcomes we would generate with alternative uses of those resources. And to do so requires a strong understanding of what benefits we forego by costs falling on different budgets. I've got colleagues in York who spend a lot of time looking at this, looking at the marginal productivity of healthcare, of the general healthcare spending, marginal productivity of public healthcare spending, marginal productivity of social care spending. And we need to understand these so we can understand what the impact of cost pulling on those budgets are. But they also tell us something actually about how society values these different silos and these different objectives, which can be useful to inform decision making. So sorry, that was a bit of a whistle-stop tour of some of the work research I've been involved in recently. But just to highlight, it's really important to consider the perspectives of the decision makers involved, and not to impose your own views, but to actually reflect back what those values are. Make sure the appropriate analyses of evaluations are done, which are wide enough to capture all the effects of interest. And the opportunity costs, are crucial to this as well. It's not just a direct benefit. We need to be symmetrical and also capture what we're forgoing as a result of introducing a policy. So yeah, thank you.
Very helpful. I'm going to turn the mic over to Rachel. I think that your work previously and in your newest role certainly touches on many of the points that Simon has made, whether it's interventions or opportunity costs or the values and understanding. Can you tell us about your work?
Sure. Thank you, Dora, and really appreciate this opportunity and the robust dialogue. Partially, I wanted to take a step back. I was reflecting in preparation for this on some of the sentinel influences in my own development as a researcher, and I keep on returning to three contributions over the centuries that I think are really timely for the conversation now and the moment that we're in. And the first is early exposure to the work of William Edward Burghardt Du Bois, and then subsequent awareness of his in-depth articulation of the connections linking social conditions and health among African Americans in Philadelphia, really as a sentinel contribution to understanding the drivers of inequity in American society. And potentially beyond. And then I also think about, fast forward approximately a century later to the critical work by the National Academies, the Institute of Medicine at the time, on crossing the quality chasm, which really centered equitable care as a component of quality, which for me was kind of a foundational idea in some of my own early work. And then the subsequent unequal treatment report, which in some ways returned to try and re-articulate in a palatable form for a contemporary audience this notion that some of what drives inequities, transcends our presumptions about the way that healthcare is designed and the mission it's designed to achieve, which I think is to this point made about values and the complexity of systems already by colleagues on the panel. So in the early phases, really where I was focusing was on understanding the nature of some of the implicit characteristics of individuals in the way that patients and providers communicate, and hence the quality of the care received, and specifically was interested in looking at differences in communication quality for visits for African American patients as compared to whites during medical encounters. And for me, this was really about sort of digging under the surface of what we understand as contributors to disparities and thinking about them as the product of interactions as opposed to sort of the product of static characteristics of patients with some presumption of impartiality among physicians. And I think this is a relevant concept as well when we think about the motivations for population health improvement programs and what implicit assumptions we're making about those who we perceive as recipients of those programs and how that relates to our perceptions of the sort of purveyors or deliverers of those interventions otherwise. And then fast forwarding a bit, seeing a lot of synergies and overlap or in some of the concepts interrogated in my own work around health impact assessment and sort of looking at non-health sector policies, and particularly in my local context, doing some work over more than a decade now in specifically looking at decision-making around urban planning policy in Baltimore City and how that could be seen as a component of a strategy to address the conditions in communities and neighborhoods that impact health and health trajectories. And from that work, more recently, I've been really privileged to have community of colleagues, and one colleague in particular who, Pam Matson, who's in the Division of Adolescent Medicine at Hopkins, who has really been taking that work we did around policy reforms and specific reforms informed by public health evidence to suggest that reducing alcohol outlet density in Baltimore City through zoning would be a part of improving the sort of health promoting characteristics of neighborhoods and our communities, to really interrogate the systems and the complexity around a targeted intervention to address a particular component of the system, which I think gets to the point that Sherry was making early on in our dialogue about complexity and understanding and embracing complexity in our work. And in that context, have together and really with Pam at the helm, we've been thinking a lot about the multitude of responses within a system to an intervention on a single component of that system, and the extent to which a system responds in a way that that propels change or improvement, or antithetical to that, that sort of reinforces the existing status quo and what else might be required for an intervention to have a desired effect that may run counter to centuries of reproducing patterns in the way that a set of circumstances are linked to the health of populations. So for me, it's really this notion that, as a researcher, we're trying to distill to those critical elements, and yet at the same time, we're faced with, the sort of facts on the ground that suggest that some of the reproducing phenomenon in population health really are driven by more than a single intervention, and understanding how we can employ and leverage the wisdom of those experiencing conditions to help us interrogate how that system is actually functioning versus, from an idealistic and, maybe quantitative empirical standpoint, we might presume it to work based on a dispassionate analysis of, the quantitative data at our disposal. So really trying to understand how we combine those complex methodologies, that really rely on quantitative data at scale with what we know to be the wisdom and the observations and the experiences of people on the ground as to the differences between how a system is perceived to function in its conception, or how a set of interventions are perceived to function and affect individuals, versus sort of the thorniness that comes to be when we go from a set of policies in the abstract to conditions on the ground, and a variety of individual interactions that may or may not suffer from sort of systematic differences in the way we create spaces with other people in those interactions. And again, that sort of brings me full circle back to, the intention of a physician to do what's right for the health of an individual patient in front of them, and the difficulty that we face in confronting a combination of empiric data or, perceptions from those on the receiving end of our interventions as to what is actually communicated in the context of our desire to help, and what the consequences of that interaction, that space between people, or, between a variety of actors in a community, and what that generates. So I think it's scary as a researcher sometimes to go for complexity, because it's hard to distill into actionable components. And yet the situation we're in today is both complex and simple at the same time. Simple in the sense that it's a relative constant that we could almost imagine into the future without sort of intentional changes, and complex in that it elements may be so entrenched that undoing them requires a new level of creativity in our science and in our implementation.
Thank you. That was very helpful. I love also the way you tied it back to what's happening in practice with people on the ground, and how the implications there. With that, I'd love to turn it over to Jacob, to you, to hear more about your work.
Sure, thank you. I have to admit that I'm maybe a little bit out of my depth as a non-health researcher, but I hope I can provide some context within which we can discuss these really important issues. I study racial inequality primarily through an analysis of space and place. Most of my research focuses on the causes and consequences of residential segregation and other forms of housing opportunity. And recently, I've been particularly interested in understanding the legacy of explicitly segregationist federal housing policy adopted during the New Deal in the 1930s. For those who may be unfamiliar, these were policies that really created the American Homeownership Society, the Homeowners Loan Corporation, the Federal Housing Administration, and the GI Bill. But through redlining, racially restrictive covenants, and underwriting rules, they explicitly discriminated against people and communities of color. There's a growing body of work causally linking these massive investments in homeownership to a wide range of contemporary inequalities. Some of my own work on this has shown that places that were redlined by the federal government almost a century ago are more segregated today, have lower levels of upward economic mobility today. It's harder to get mortgage credit there, and there are wider racial wealth gaps there. And I think this is not only valuable from the perspective of policy evaluation, but it helps explain some of what Rachel was referring to so eloquently before, the kind of intransigence of inequality over time. And what Pat Sharkey refers to as people being stuck in place, or what Maria Kreisen and Kyle Crowder refer to as the momentum of segregation and inequality, as well as what many scholars have shown about a growing racial wealth gap. These unprecedented at the time and unrepeated since government interventions in the middle of the last century exacerbated existing inequalities at the time and really made it incredibly difficult to undo the damage. And I could talk about housing policy forever, and I know that's not the focus of this panel. But my point, hopefully, is that the health crises facing communities of color today are generations, if not centuries, in the making. If we think about the current pandemic, there's very recent and innovative work by Gerard Torres Espinosa showing that more segregated places had higher mortality and infection rates overall, and larger racial inequalities in COVID mortality. Some nascent work of mine suggests that some of this may be due to federal redlining. There was a report recently by the National Community Reinvestment Coalition showing that historically redlined neighborhoods have a higher prevalence of COVID risk factors. And there's about a half dozen papers linking measures of housing quality, like crowding, and instability, like evictions, to COVID risk. And of course, the unfortunate vaccine reluctance in communities of color is linked to a wholly justified skepticism of the medical industry due to historical practices of exclusion and exploitation. And there are, of course, parallel stories related to lead poisoning, obesity, heart disease, what have you. Sherry and I have work showing that foreclosures have these negative health consequences. And just to sum up here, I think that there are two important lessons in this work. The first of which, again, is that the inequalities that we see today were intentionally constructed, and therefore we have a moral obligation to address them. And I think this also has implications for how we talk about the social determinants of health, because we often fall into language problematizing communities of color, for example, through deficit models. And this is one example of the way in which the social too easily becomes blame and narrowly constructed non-structural solutions. And the second thing, and then I'll wrap up or stop talking, is that, again, these are multi-generational problems. And so because of that, policy solutions need to be very long-term in scope. And this is hard to say as a researcher because it requires a multi-generational patience that we might not see the impacts of interventions for 10 years, 20 years. Some work that I'm looking at now is showing that the housing wealth inequality created by redlining didn't show up until the generation that inherited the immediate benefits of redlining became adults. And this was also evident in the initial and then longer term research on the Moving to Opportunity program. That initially, again, there were little signs of any benefit, and I don't know why we would expect there would have been, given, again, the multi-generational nature of poverty and inequality, that moving somebody to a slightly less impoverished neighborhood for a few years would have these transformative effects. But it turns out, if you take the longer view, that those types of moves can have transformative effects, especially for people of younger generations. So I'll stop there and hand off the mic.
It's fantastic. I can think of so many follow-up questions that I know that many of your messages have resonated with different people in different ways on this panel from our side conversations. So we'll certainly be following up. Chapin, you have the very difficult task of going last and explaining how, from CBO's perspective, how do we influence policymakers? How are we supporting these interventions that cross sectors, health and social services? And tell us how CBO approaches these types of matters.
Okay, thank you, Dora. So I'm the Deputy Director of the Health Analysis Division at CBO. CBO is a congressional support agency. We're a small agency. We only have about 270 people, and we work both for the House and the Senate. We work for both parties in Congress, and our core tasks are to project the federal budget, including revenues, outlays, and deficits, and to project the impact of proposed legislation, again, on revenues, outlays, and deficits. We don't make policy recommendations. We just describe the financial trade-offs from the federal budget perspective. So we do a ton of work in the healthcare space, and that's because the federal budget is deeply entwined with healthcare and healthcare policy. So we do work on preventive healthcare, opioid use disorder, prescription drug pricing, and I see there's a text question about research and policy analysis relating to drug pricing. We have a ton of work in that space. We look at health insurance expansions, but our role is only to assign price tags. We don't look at the health impacts or health equity as an outcome in and of itself. We don't do nonpartisan objective health impact assessments the way we do federal budget assessments. Now, our analysis speaks to, does something reduce the federal deficit or increase it? That's not the right metric for success in health policy, and I know that. Let me give you an example. We've done some work on excise taxes for cigarettes. We have a report that came out in 2012. We look at how much revenues we would get from higher taxes, how many fewer people would smoke, how many more people would be in better health and so would be in the labor force and generating tax revenues. We also look at how many people live longer, and we quantify how that would increase Social Security costs and Medicare because more people would survive to claim those benefits. That's why we don't get invited to many parties, but that's the lens, is what's the impact on the federal deficit. The health effects are relevant, but that's not the endpoint of our work. And I see a lot of folks in the policy space frustrated with CBO and saying things like, preventive healthcare is clearly a good thing. If only CBO would score it as a saver, as reducing the federal deficit, then we could get more of it. But our core task is just to look at deficits, federal deficits, and we supply the price tag, and we're relying on other researchers, other folks in the policy community to describe, quantify the benefits of what you get from improved health or improved longevity. We're doing more work on distributional impacts. Those mostly are focusing on distribution of tax credits, and we're really not geared up to talk about distribution of health status or health equity. But that's something that's very much on our radar. In terms of siloing is a very natural part of the process in that congressional committees have limited jurisdiction. That kind of comes to the forefront when you see a big reconciliation package passing through Congress the way it just did. Committees are only given slices of the world that they have some authority over, and that kind of fragmentation flows through to the way we analyze policies. We tend to do it budget account by budget account and federal program by federal program. There's I think it's also important to point out there's in terms of decision making, that in the U.S. we have a pluralistic society. The federal government has a lot of influence, but is also limited in many ways. The state governments have jurisdiction over a lot of what goes on. The private sector has a lot of jurisdiction over what goes on. There's, in general, no one switch point to be making allocation decisions across complicated things like housing versus food versus healthcare. Those decisions get made at multiple levels by multiple diffuse decision makers. So let me pause there, and I'm interested to hear questions and comments from the other presenters.
Absolutely. So maybe we'll just continue on from there. I will take the moderator's prerogative and ask the first round of questions. Maybe starting with Simon, you've just heard from Chapin about how the CBO process works here and the tension between focusing on health impact versus the price tag to our federal programs. How has this issue played out in the UK? Do you have any insights or advice for us? Any comparisons that would be interesting to hear?
Well, whether I can offer advice, I'm not so sure. It sounds like an interesting process going ahead there. It's an interesting objective focusing solely on the budget deficit. I guess from the UK, there's sort of different lessons from different sectors. Within the sort of healthcare sector, the NHS places a pretty strong emphasis on evaluating investments in terms of their impact on health, and comparing that to the opportunity costs to see whether we see improvements in population health and the distribution of that health. How it's achieved that? Well, I guess bodies such as the National Institute of Health and Care Excellence have played a sort of key role with setting out sort of strong guidance about how we should conduct policy evaluations to inform policy with that focus on health improvement. More broadly, the HM Treasury, which is our finance ministry, also sets out quite clear guidelines on how policies should be evaluated in terms of their benefits and costs to say whether they're beneficial or not. So ideally, it sounds like we're trying to improve these goals, but there's undoubtedly been cases in the UK where it's been decision making has been much more around cost saving, balancing budgets, and the discussions which you have in the US sound very true. So in the UK, we've had 10 years of austerity now, and undoubtedly many decision makers, particularly at the local level, where budgets have been really hard hit, have had to focus very heavily on cost control, cost containment, rather than thinking about how do they maximise the objectives, how do they set out a series of investments to improve their objectives. It's very much about how our budget's been reduced by 20 million. How do we claw that back? How do we break even? And I guess that's particularly interesting because now within public health, where I think you mentioned that Jacob and others have mentioned the long run nature of it, the importance of not being myopic, actually thinking about the long run value of investments, and particularly sort of focusing on short run cost containment. But not budget is particularly damaging in this setting where you're trying to achieve these sort of long term goals. I say, unfortunately, we haven't escaped these problems in the UK either.
All right, and I'm just picking back up on that, Chapin, to Jacob's point that these are often a multi-generational. We have to look at these over the long term. How does that play? I mean, I know you have your budget window, sometimes 10 years or however you score, but do you account for that in your process?
The short answer is yes. We We typically focus on the next 10 years, but we also do analyses looking 30 years out. But the scope of what we project 30 years out is just federal revenues, federal outlays, and the deficit and the debt to GDP ratio. That's not the right lens for assessing whether the trajectory of the health status of the population is moving in the right direction or not. It's really inadequate to address that health question.
Right. So no escaping those limitations. So Mina, I'm going to turn to you. You've heard from Simon in terms of the difficulty of generating information. It can be complicated when the policy relies on multiple decision makers with differing objectives. Do you have any examples of how that's played out in Maryland or through your health system?
Yeah, absolutely. I mean, so the work that we do, it's around community health, palliative care, primary care, geriatrics, chronic disease management. These are a lot of areas that do not fit within a particular, office visit, E&M code, CPT code, because they're intended to think about caring for people in a more holistic way. But then that falls prey to some of these silos in terms of being able to get a true sense of the value and impact. So, as one example, we have received a grant with it's like 17 hospitals in the Baltimore region on behavioral health crisis intervention. So being able to have a, crisis rapid response with, a mobile crisis unit and access to same-day services. And because it is being done with, the healthcare system, a lot of the metrics are looking at, reduction in ED utilization, reduction in hospitalization, which are important. And there are also tremendous opportunities around being able to provide behavioral health service and have people helped in the way that actually helps them the most, in terms of how does that impact the justice system? How does it impact productivity in the workplace? How does it impact family dynamics and how, divorce rates and abuse rates? There are so many other aspects to an intervention like this that it's very helpful. This is where bringing together multiple stakeholders is important, because then you can start to piece together the different pieces and have the different impacts. But to pick up on something that Rachel said, it's also important for us to not just think about quantitative, but qualitative, because ultimately so much of what we do in healthcare is about helping communities, that it's important that you move the metrics, but it's also about creating that sense of well-being and that sense of community. So, another example, we have, we're part of Safe Street. So we have people who have survived gun violence can then be trained as a mediator. When someone comes into our hospital, either a victim or a perpetrator of gun violence, a mediator is assigned to them to help them to avoid that in the future. Certainly, you could, again, from that health system, health perspective, just take the lens of, we are avoiding, subsequent violence, which is reducing, hospitalizations and ED utilization. But I think it goes without saying that the impact of a program like that extends far beyond those walls, and also extends beyond the metrics that you would look at, because you're creating senses of community. To get to Jacob's point about that intergenerational aspect to it, where you have people who were in that situation are now helping the next generation, there have to be ways that we are thinking about this in a more holistic way, both quantitative and qualitative, and thinking about both short term, because again, long-range financial forecasts are often 5 years, right? But a lot of these things go well beyond. So how do we both think quantitative and qualitative? How do we think health and social? And how do we think, short-term, long-term?
Right. Yeah. And so thinking about getting back to the metrics in terms of thinking short-term, long-term, Sherry, you mentioned in your remarks that the evidence base for many interventions, perhaps that some of the ones that mentioned here is limited, but you said there are some clear winners, particularly transferring income to very low-income families with significant health risk. And so in that context, I would love to hear your thoughts on the increased child tax credit the increased child tax credit that just passed is part of the American Rescue Plan Act.
Well, so first of all, that is totally wonderful news. It's a really great thing because families need, low-income families need income. They need income more than they need anything else. And the estimates suggest that the new child tax credit will have very significant effects in terms of the number of children brought out of poverty. There was a recent paper actually looking at a similar program in Canada that found very significant effect on childhood poverty. And one of the concerns people have had is that programs like the child tax credit would lead families to drop out of the labor market and to stop working, which might not be a good thing. It's arguable whether it's a good thing or not anyway. At least the Canadian experience suggests that doesn't happen either. Families just need that money and it's really useful to them. And then I think the other piece of what we know from the health world is, and I don't know exactly how to think about it. It's kind of, maybe Chapin or somebody, it's philosophically very interesting, or Simon. We're just so much more comfortable giving people in-kind services, housing, food, whatever, than we are in giving them income. But the most robust evidence on the effects of social determinants on health is about income. When you give families income, they do better. They do better in terms of mental health. They do better in terms of housing, and everything else is better, which is sort of like what your grandmother used to say, right? My grandmother used to say, it doesn't matter whether you're rich or poor as long as you have money. And I think at the end of the day, she was right. Because it helps you buy all the other things that you need. I actually want to echo some of the things that several other people were saying, Nina, Rachel, particularly, Jacob. A lot of the benefits we're looking for in terms of people's lives just don't fall so neatly into the health rubric, and certainly not in the short run health rubric. Like the moving to opportunity evidence in the short run on health is pretty corrupt, pretty uninspiring, but the longer run evidence is much stronger. We're much more comfortable in making costly investments in medical care, even though they're just going to drive up the budget deficit, Chapin. If Chapin had to actually figure out what the value of a lot of Medicare increases were, he'd be really, his hair would fall out. But if you had to do it, when we think about these interventions, they may have benefits, but they may not pay off for a long time. And that is a decision that involves making trade-offs and thinking about ethics and morality in a way that Simon was talking about, that our legislators should be able to do, and that we should be giving them the information to be able to do. That was a long answer.
Chapin, do you want to respond to Sherry's comment? And then even to think more broadly, is there a way for researchers to help policymakers make a better case to CBO on these issues?
Well, we track what's going on, but I think it's relatively straightforward to talk about financial impacts of expanded access to medical care, let's say, or the child care tax credits. It's very challenging to think about improved well-being. We have some work going on looking at what are the long-run effects on earnings of people being eligible for Medicaid when they're children, for example. There's an emerging evidence base there. That's a tricky research question. We're tracking what's coming out in that area, and it's relevant to what we do. But our role is just to try to quantify financial trade-offs, and decision makers need a much broader set of information, and we're really relying on the outside research community to fill that gap.
And then I see there's a question for you in the chat that maybe if you could just answer. Do you only look at federal policy, or do you also look at state and its interaction with federal when you're exploring price tags?
Right. So we have to track what states do. The states have huge decision-making authority in the Medicaid space in particular, and we have to anticipate how states will respond to what the federal government does. But we're most directly on the hook for projecting what will happen in the federal space. And we don't project state outlays or report our projections of state outlays, but we clearly have to track what states are doing.
Thank you. So Jacob, I want to turn to you. Of course, I was intrigued when Sherry said it's much easier to provide housing support if income is the hardest. And I was like, oh, the housing is so hard. So I'd be curious to hear your thoughts on that. But also just staying in the policy realm, given this new administration's and their early executive actions on racial justice and equity, how could they translate some of your research insights that you shared into federal policies or programs? Are we in a place where this is translational, or what, or is additional research needed?
I really love this question, and it's because one of the lessons from this growing body of work is that we know what we did to segregate people. Effectively, we paid this group of people to live over here, and we paid this group of people to live over here. And we did that over the course of generations. And that provides a model for undoing it. I think thinking about the current administration, the encouraging things from my seat as a housing and neighborhood person are they're reinstating the affirmatively furthering fair housing rule of HUD, the willingness to study reparations, which is really a pretty transformative moment. And as Sherry spoke to earlier, the stimulus package making the social and safety net more robust. Then in places where I think that I would like to see them go further on policy, and if we think back to, again, the enormous crisis of the Great Depression and then the New Deal, this was really a restructuring of the social contract and specifically the role of government in protecting individuals from hardship. And we're not seeing the types of transformative policy ideas that characterize the New Deal. The exclusion of people of color notwithstanding, right? But the Civil Works Administration put 4 million people to work in 2 months in 1933. To adjust that for population, that's the equivalent of 10 million jobs today. And when we think about housing policy specifically, there are lots of models for anti-racist housing policy. The one that perhaps got the furthest was George Romney's Open Communities plan that he tried to secretly implement under the nose of Richard Nixon. Unfortunately, Nixon found out about it and stopped it. But Romney wanted to invest in previously redlined neighborhoods, 2, build affordable housing and opportunities for homeownership for African Americans in affluent white neighborhoods, and most importantly, he wanted to grant the federal government power to overdo local zoning provisions. These things were suggested in the late 60s, and we were already in an affordable housing crisis before the pandemic. That's clearly been exacerbated by joblessness and all of the other consequences. And so, some people are making interesting points about ways to use residential and commercial evictions and vacancies in really a once-in-generation opportunity to invest in historically excluded communities and create opportunities for mobility to high opportunity areas. In terms of research, I'm an academic, so I will always say there's always more research to be done. Plus, that's also what gets me a promotion. But again, I think we're undoubtedly in a time of widening inequality, and just in 1 year, life expectancy drops 1 year on average, but 3 full years for Black men. And I think understanding the full consequences of this period, won't be understandable for quite a long time, especially again, given the multi-generational nature of things. And when we think about wealth and housing and neighborhood attainment, which is where my research is. I'll stop there. I saw there was a question in the chat about connecting the dots between redlining and COVID. If I could just respond to that quickly, I'll share the data for redlining in a response to that question. It's all available online for free on the Mapping Inequality website. The challenge on the connecting that to COVID data is the lack of neighborhood level COVID data. That's only available in a few dozen cities and states. There's no comprehensive national data set.
But more generally then, Jacob, before you go, just to broaden out the question a little bit more in the chat, I mean, how do we help health sector leaders collaborate with social scientists? I mean, are there structures in place? Are you aware of any type of, whether formal or informal collaboratives that could demonstrate that this can be done and can be done well?
I mean, I'm always open to collaboration, but I think that there are a number of institutional resources available. I know that my institution, New York University, is funding that kind of research and supporting that kind of work. And one of the things that I found somewhat lacking in the first 4 to 6 months of the pandemic was the voice of social science, and I think some of that has to do with where social scientists kind of fit in the hierarchy of expertise when thinking about these things, and it's also a function just pragmatically of our research and publication timeline, which is just painfully long. But there are growing models for disrupting that process.
Yeah, I would say in terms of COVID, the COVID Equity Task Force that was announced more than a month ago, I mean, I did think it was notable. It was inclusive of the Department of Health and Human Services, but also the Department of Housing and Urban Development, the U.S. Department of Agriculture, the Department of other federal departments. And so I do think that this more holistic view of health and what needs to be addressed in order to, what we need to invest in to get to health is something that's clearly a priority for the incoming administration. Rachel, I want to talk to you. You talked about the alcohol and zoning policy. We've heard about income. We've heard about other SDOH areas of work. Can you share any other successful efforts to provide real-time feedback to providers and systems, or other initiatives that have actually been able to interrupt the perpetuation of inequities? And do you feel that we know enough about how to do that?
Well, I think to the latter part of the question, I don't think we know enough about how to do that at the level of providers. And I just have to give a shout out to Lisa Cooper, a longtime mentor, the director of the Center for Health Equity at Hopkins, who was really the conduit for me to get my start looking at the way we communicate, the way physicians and patients communicate in those interpersonal interactions. But the one place that I've been thinking about a fair amount, I can't say that I've fully interrogated the data, but to this question earlier about opportunities for healthcare, both as a sort of in population health research, but also in healthcare delivery, for us to think about how we better partner and leverage the knowledge that exists in other places that we do not have to reinvent, but maybe have to discover for the first time. I've been thinking a fair amount about work by Jennifer Eberhardt that I think I actually heard presented at a National Academies event about a year and a half ago, who's a social scientist thinking specifically about how in the criminal justice sector, decisions get made based on a knee-jerk reaction to a physical assessment of an individual person with whom we're presented. And it relates a lot to, I think, much of the subsequent work to the unequal treatment report that has looked at the cognitive processes that may be impacting the decision-making by providers. I do think we fall short, and one of the suggestions there may be that we need to figure out ways to slow providers down in their interpersonal decision-making, and potentially to utilize some of these fancy technologies that are being deployed otherwise to kind of pre-chart for us or take our words and turn them into a distillation of the plan from a visit or something of that nature to provide some kind of feedback. I mean, I think it would be a ripe area for research to really think about how we leverage technology, and technology that has behind it a diversity of perspectives and experiences among the researchers building and testing the technology and how we might respond to it, to think about how we slow down cognitive processes that might at the level of a patient be getting in the way of a considered decision about the treatment trajectory for that individual. But I would come back as well to, I think, another place where there's a really ripe opportunity for us to be more considerate of the tremendous scholarship and unearthing of scholarship that I think is potentially happening in this moment, to even think about our colleagues in history and the humanities, history of medicine, for us to start understanding in more detail the profession in which we operate and the sort of everyday nature of how we approach decision-making and the extent to which that derives from a set of constructs in which we've been trained that really provides primacy to a certain set of experiences and sort of discounts, again, coming back to the point of the way we might approach scholarship that has long existed to articulate phenomena that we have, felt a persistent need to restudy before we can come to acceptance of those phenomena. So I don't have the answer to that, but I do think it's a ripe area where there's room for us to think in practice about slowing down the shorthand language that we're using to even describe things such as the social conditions that affect people's health, how we might characterize those, how we might attribute those to society as opposed to attributing those to the individuals affected, and also how we might expand our lens from one that really focuses on the potential negative impacts of social conditions on health to fully recognize the bivalent impact of social conditions on health, and get in the weeds a little bit more on those key interventions and those key conditions in society that potentiate and perpetuate positive health trajectories, to Sherry's earlier point about having money to buy things people need to survive and thrive. But I do think on some level there is still a fundamental grappling with why it is that it's unpalatable in certain contexts for us to think about empowering people and specific subsets of the population to have that self-determination to invest in their own well-being. And I think about this in the context of work we've done just in a small pilot study around the use of SNAP benefits in our local community, and all of the myriad things that the parents we talk to who are extremely low income are thinking about in the use of those benefits that extends beyond, the minimum requirements we might have, which is to use those benefits to provide nutritious meals to their children. But those benefits become a conduit potentially for those with extremely limited financial resources to provide rewards for the good works their children do, to provide access to opportunities to interact with social environments and to avail themselves of experiences that teach you how to navigate a restaurant or a store, for example. to potentiate child development. And so I think there is really kind of an important opportunity for those of us in healthcare, given the primacy and the relevance it always has, to take a step back and think about when the dollars flow elsewhere, how those dollars are also impacting the health and the lived experiences of the patients that many of us care so deeply about. And then I think the other is just to kind of slow ourselves down when we presume that a certain rationale for an investment makes sense, to kind of unpack what we're assuming in that context and to sort of make explicit and seen some of the assumptions that, without realizing it, or go unseen. I don't think that social science necessarily has the answer to that yet, but I do think it's a fruitful area for us to think about collaborating with our colleagues in the social sciences to understand how we might leverage what they've learned elsewhere.
Very interesting. So not to put you on the spot, but I obviously with the temporary increase in SNAP, also through the American Rescue Plan Act, I wonder, from your work in this area and thinking about not just the strict nutrition benefits, but all of these other factors, that are there any policy recommendations based on the work that you've done in your research that we would modify the program or think differently about the benefits? Or is that still just perhaps too new or not within your area? That's a fair answer too.
I'm not sure if I have the complete answer to that. I would hearken to, the privilege I had to serve on a National Academy study panel specifically focused on summertime experiences for children and youth. And in that context, we did highlight the importance or the potential value of expanding benefits and the research in the area over the summertime for those children who are otherwise reliant on access to food in school. And I think shortly or in some short order after, thinking through it in the summertime context, much of the work that we did in the context of that report on summertime became really relevant to what we do when there's a precipitous closure of schools, which we really rely on for the health and well-being of children in so many ways. So that would be one that I think I could legitimately call to. And I think beyond that, there's significant expertise in this space. And I would, invite anyone who's listening, who's expert in this area also to chime in with additional thoughts. I do think there's a real set of conscious reflections that we should be making when we think about limiting access to specific categories of goods with these type of benefits, and to be really cognizant of why we might be doing that, and whether that's really what's required to sort of optimize people's ability to use the benefits for nutritious foods or otherwise.
Right. So with that, Sherry, I'm actually curious. What do you think about the interventions in terms of SNAP? How does that rate? Do we know how does that rate to like the childhood tax credit or other income?
Great question, because we're actually just beginning a study on it. Most of the research that's been done on SNAP, which I think sort of is consistent with the conversation generally, has been looking at the timing of SNAP and the effects on things like hypoglycemia, if people's benefits run out at the end of the month. That literature is actually pretty weak. The results are very contradictory from different studies. But the more interesting to me aspect of SNAP is that, people have to buy food. So if you give them SNAP benefits, they actually have more cash on hand for both food and other things. And how does that affect their outcomes? So that work hasn't really been done yet in terms of the health outcomes. And it's actually something we're embarking on, hopefully next week.
Mm-hmm. Okay. All right. So we're at the cutting edge with that.
Stay tuned.
There is a question in the chat that perhaps if you just want to pick up on that, you spoke to the reluctance to give people cash income, even if it's supported by the evidence. How do we persuade decision makers when values, as Simon noted, differ?
Well, I mean, I do think that the success of the child tax credit and even the bipartisan nature of some of the conversation around it is very encouraging in that respect. But people do worry, particularly about the labor supply effects of cash benefits in a way that they don't worry as much. I don't know why not, about the labor supply effects of non-cash benefits. So they worry a lot that if we give people money, they're just going to stop working, and that would make them, I don't know, terrible people or something. There's an argument to be made, and there's some evidence that Raj Chetty and others have put forward that actually having parents who work is really good for children, and actually increases the probability that they will do better than other similar kids. That living in a neighborhood where lots of people are working is really important, and I think Jacob alluded to some of that in terms of large-scale public works kinds of projects as ways to move forward. And there's an argument to be had about guaranteed jobs versus guaranteed income. So, we're starting to hear a little bit of that conversation. What happens, I mean, frankly, what goes on here is that when you give people non-cash benefits, there are two sets of political beneficiaries of that action. There are the families who get the money or the food stamps or the housing, and there are the suppliers of those things who also get a new market, like the farmers and the housing developers. And this is most powerful, we know, in Medicaid, right? Medicaid is a really robust program because it's not just poor families who benefit, but also hospitals and doctors and other people who are much more able to lobby and get things to work for them. Cash doesn't have that lovely supply side lobbying potential. We need to build it. Spend your money here.
Very helpful. So then, Simon, I want to turn this back to you. There's a question, well, it's not exactly directly to you, but it does mention UK. So of course I automatically turn to you. Fair or not, I guess Mina spent time in the UK too. So the UK contingent can take this one on. The UK adjusts healthcare payments and social services for neighborhood deprivation indices to improve equity, puts more resources where needed. We could do the same. Are you familiar with that, Simon? Do you agree with that characterization?
No, it's a fair characterization, particularly of the way that we allocate healthcare payments for the NHS. So we sort of pay capitation payments, particularly to primary care physicians, based on the level of deprivation within their authorities. The system and the formulas used to do it are quite dated now, and I know that we are looking at updating them. But obviously, yeah, the belief is that there is more health can be gained by individuals in more deprived areas, and therefore we try to push public funding towards those areas via specific resource allocation funding. How successful they've been, it's debatable. Again, it's heavily focused towards funding interactions with the doctor rather than towards the sort of public health, where actually might be the really important drivers of health in more deprived areas. So focusing on the determinants, it's very much more focused on that the individuals in deprived areas are more likely to have healthcare needs, and therefore doctors need to be funded to provide those, rather than actually go and say, how do we really go about improving the health of these individuals? Which would have to focus more on.
Very interesting. And then Chapin, I see a question back to you. If healthcare needs are not met, where does that cost end up? Does CBO quantify that kind of cost?
If there's really direct, clear evidence, we will quantify it. But again, if healthcare needs aren't met, the most salient, important result is somebody's health is harmed, and that we're really not set up to quantify or report. But we do definitely track if there are spillovers from people not getting one thing on something else. We do try to track that if the evidence is compelling.
Could you give an example of that?
Let's see. I mean, the smoking the smoking report that I referenced before, I could actually put a link to that in the chat. Is a nice example of a very well fleshed out, thinking through all the chains of causality. I'm not sure if there are other examples. I'll try to think of those and maybe put them in the chat.
Okay, that would be great. Oh, and sorry, there's another follow-on for you. Maybe Chapin can't speak to this, but is a congressional entity, like an update of the OTA, but for health, needed to do what CBO can't? I guess that's not directly to you. Others may want to opine if we need a CBO adjacent type entity to.
That's above my pay grade. Interested to hear what others think.
He's like, I'm gonna leave that one alone. That might be too sensitive. Mina, here's a question that I'll ask you. Social scientists, medical professionals, economists, etc., have been working together in the CMS quality improvement program in the past. From your prior time in the administration, did you have a sense of how these different disciplines work together? And I guess, Jerry, you may have an opinion on that as well, given your time in ASPE. I mean, how integrated were these teams, or would you say it was still more siloed than not? And have you seen any improvement?
I think there was a significant effort to bring together various stakeholders and perspectives. You know, one example is the Healthcare Payment Learning and Action Network that was developed that, you know, brought together the patient perspective, providers, payers, employers to, you know, really look at how do we drive value in the healthcare system. And I think there is a recognition that that kind of bringing together the various perspectives is going to be important. And even just when you are looking at quality and outcomes in a program, to be able to bridge the economic, the sociological, the clinical together in creating like sets of quality metrics or outcomes that you want a program to achieve is something that is very important.
Okay. Sherry, can you add to that in terms of?
I mean, I think there were many efforts, and some of them quite successful, to bring people together across within the department and across HUD, for example, and HHS, working on a variety of housing-related health issues. You know, it's an interesting challenge because there is a tension between running a program well within itself and collaborating with others on the outside who have different goals and different missions. And it's a tension we have to navigate because collaboration is so critical, but we also can't ignore that it's there. It's a mistake to believe. I got my start working on mental health, and there's a really depressing result in child mental health. It's just like a really depressing study. I don't know, should I ruin your afternoon with a really depressing study? It's called the Fort Bragg study. There was a long belief for a long time in mental health, child mental health, that, you know, you could do a lot better for these kids who were really troubled if you just bring together all the people who touch them, that, you know, these kids who were involved with multiple systems, and if you just get everybody around a table and working together, that you'd really do much better for these kids. And there was a lot of funding put into several projects to try and do it. And the outcome was people were somewhat more satisfied with the services when they didn't have these overlapping demands and when people were getting together, but the kids didn't do any better. How well the kids did really was sort of a function of how good was the best service you could provide to them. And it taught me a lesson, which is that, you know, it is a mistake to imagine that there are great gains from collaboration alone. The gains come from providing a better service. And if you can't provide a better service by just sitting around a table, sometimes the best way to provide a better service is just to get whoever provides the service to do it better. So collaboration is really important, and we also have to be also very good in our silos. So everything, we have to do everything. That's what I tell Jacob. That's how you get promoted. You do everything.
Yeah. And I do want to turn back to Rachel and Jacob. Sometimes when I'm thinking, I'm like 2 steps behind the conversation. So I do want to go back. Rachel, when you're talking about we have to slow providers down or cognitive processes, are you getting at like an implicit bias when you're talking about decision making and how we're thinking about patients? Or were you touching on that, or is it something more general? And also then with Jacob too, I mean, you are focused on housing, of course, but racial inequality, racial equality more generally, and you talked about segregation. I mean, how do we think about addressing racism as part of this agenda? How do you employ an anti-racist agenda even more broadly, even outside of the housing context? And so I'd love for both of you just to talk more directly about those types of issues and the opportunities and challenges with that.
Do you want to start, Jacob, or?
This is like you start.
So I think in part that was kind of what I was referring to a bit. I think that, you know, I wouldn't want to dwell too long on the role of individuals, but I do think when you are with an individual, and I think of several categories of service professions, doctors being one of them, where when what a person really needs in that moment is appropriate recognition of the threat to health and well-being that is in front of the patient, we do need mechanisms by which to improve our ability to respond in real time in a just and appropriate way for all patients in need of our services. And I see parallels to a lot of other service professions in that. Is part of that reflective, and this is sort of me opining, I think in an emerging space of data and knowledge integration, is part of that about a cognitive process happening at the individual level that has maybe known popularly as implicit bias, or some heuristic we're using to categorize a problem and respond accordingly based on our rapid assessment. I think the answer is yes. Is that also operating within a structural context that reinforces the appropriateness and validity of that set of behaviors? You know, I think yes. And so if the kind of a system level or structural response with applicability to the individual might be for the methods and the requirements within that system to be successful as a professional in that space, to require something different of us as professionals, not to change us for the sake of, you know, it's good for us to be less biased, but because the system requires us to behave in a different way. And so I just want to be really explicit about that distinction. I think it is, it's unfortunate when our conversation and our approach to problem identification focuses disproportionately on interpersonal, when that interpersonal exists inside of a set of constraints and assumptions and sort of implicit operating models that we do not articulate explicitly, even in the training of physicians. And that, I think Jacob alluded to this at the beginning, and I'd love to hear more about it, but I tend to also think that is we now run the risk of with the language of social determinants. And again, the application of a set of conditions that is not individualized as if they were characteristics of individuals. And I think this is something that continues to repeat itself in different ways, coming from a place of good intentions, potentially. I don't want to speak to people's intentions, but that is unfortunate, and to the extent that it reproduces, I think, in our own context in Maryland and some of the
pass the baton to Jacob to expand upon these thoughts or just share your thinking. And I appreciate Rachel's overall point is that make sure we're thinking at the systems and policy level, and which will be more productive. But thoughts on that?
Yeah, I fully agree with Rachel, and just would kind of piggyback on the point that when in healthcare or in policing or housing or employment or education, we too often focus narrowly on the interpersonal and solely define racism as discrimination, whether that's implicit bias, which we know many, if not most of us carry, as well as explicit bias, which in the healthcare sector, study after study has shown that that explicit bias is a huge problem as well. That large portions of doctors, for instance, believe that African Americans have higher pain tolerances than whites. That's not an implicit bias. But just to again reiterate Rachel's point, that if we were somehow able to magically eliminate racial bias in all aspects of life, we would still have the tools and kind of structure for reproducing inequality by race, because again, we've been building these inequalities for quite some time, and there are enormous socioeconomic differences in information, and from where I work, geography, that are really crucial. And these structural determinants of inequality are a far more powerful driver of disparities in health or housing or job access than any individual bias. I would say that it's a really good question to keep asking. What does an anti-racist policy look like? Because I think that we are just getting comfortable with that kind of language, and so the policy models are kind of still in formation. One example from the housing world that I have been advocating for recently is in terms of housing discrimination, temporarily going back to the interpersonal problem. The burden of proof in a housing discrimination case lies currently with the victim of housing discrimination. You have to prove that you were discriminated against based on some protected class, and doing that is almost impossible as an individual, and there's no way to do it systematically. And this happens in a context in which every single housing audit that is done shows discrimination against people of color, against single mothers, against voucher recipients, etc. And so I would prefer that we shift the burden of proof to potential discriminators, that we create reporting requirements for real estate agents, landlords, akin to the Home Mortgage Disclosure Act, which requires reporting of home mortgage applications, and also similar to the recent law change in Iceland, where they now require employers to prove that they don't discriminate against women, rather than waiting for reports of discrimination. And so, part of this is recognizing that discrimination and bias and these structural inequalities occur within an unequal power dynamic, and that that efforts towards anti-racism have to kind of grapple with that and reverse the power where possible.
Oh, that's very helpful. I think that's important. I mean, in this context, we're talking about healthcare expenditures and how do we reallocate, reinvest, but all of that has to be, these decisions have to be built on an anti-racist, or being mindful of health equity and the decisions and who and how, and getting back to Simon's notions on values. And so I do think that this is an important issue to continue to focus and infuse throughout our discussion. Certainly, I want to go through, I know we don't have a lot of time, so I'm want to pick up a few more into the questions that were in the chat. I thought I saw another one for, let's see. Yesterday, we heard about how we could reallocate wasteful healthcare spending on evidence-based interventions, Job Corps, UBI, expanded SNAP. So how do we do that? And so for all of you, probably particularly putting on your policy hats, we keep talking about that, but then how actually can we get that done? Who wants to start that one? Go ahead, Jerry.
So first of all, I actually question the premise of the argument, right? We spend more money on healthcare every year without ever actually doing the analysis about whether it does a whole lot of good. We keep increasing our spending. We should not focus on transferring that money into doing the things that we should be doing around providing income and housing and food stamps and addressing racial inequities, which are so much based, I think Jacob has pointed it out and others, on a long history of being inequitable, so that the wealth of African-American families is so much below the wealth of white families. And that's not a one-time thing, that's a consequence of generations. We shouldn't be waiting to save money in the healthcare system to fix those things. That we should not, right? It's the same argument we used to have about covering the uninsured. People used to say, we can't cover the uninsured until we cut healthcare spending. No, we have to cover the uninsured. It's a moral imperative that we cover the uninsured. We also have to cut healthcare spending. We can't tie the moral imperative to our cutting healthcare spending. We don't know how to do that. We're really lousy at it. The politics are terrible. Don't hold what we should be doing hostage to an absolutely impossible goal that has extremely strong, political forces behind it. That just disadvantages the people who most need help. There. You always get an opinion from me.
Excellent. Well, I'm pretty sure there's not going to be any disagreements with that statement. So we will move on to another question in the chat that came in earlier. Chapin, it looks like it's back to you again. Does the CBO look at packages, i.e. an initiative to decrease healthcare administrative waste with an investment in social determinants of health or public health? That might be picking up on Sherry's point, but still that is the question.
Yes, and CBO just scored the American Rescue Plan Act. That's a gargantuan package that touches many, many sectors of the economy and American life, and we scored pieces individually. We looked at the interactions, but again, we're just focusing on the federal deficit impact. There are also instances where Congress will be moving legislation that has costers, things that Congress wants to spend more money on, and savers or pay-fors. And there are rules called pay-go rules, pay-as-you-go rules that will tend to formalize the notion that this legislation must not increase the deficit overall. And so there are narrower packages that strike that balance, and we're the official scorekeepers on whether Congress has appropriately struck the balance of costers and savers. But Sherry, your overarching observation and your instinct to separate the question of what goes on in the healthcare space from what goes on in other social policy resonated, and I think is an important one.
All right. Well, we are down.
I mean, we could always raise taxes, right? We could always raise taxes, and Chapin would be happy. We could fund things by raising taxes. We don't have to fund everything by cutting.
So I'm not sure if that's the note we want to end on, but as can imagine, we'll leave that one there. So just in terms of our final word I would invite each of the panelists to create a final word. And as part of that, I would love if you just think about, if you have suggestions on how as researchers, you can help to be more persuasive to policymakers as they're thinking about these issues. That would could be part of, if there's one thing that you could do to, whether it's helping to change the narrative, or there's a different type of research or way of doing research, or newer areas of investment, I'd love to provide one suggestion for this field as you move forward as part of your final comments. And so I don't know if anyone wants to volunteer. I could to go first, or I'm happy to pick on Mina. So you, either way we go. All right, Mina, we're starting with you.
Well, I think, some of what has come about through this discussion, which has just been a fantastic panel and discussion, is the need to balance all of these various perspectives, time frames, sectors of industry, sectors of public good and welfare. I think the one thing that wasn't maybe mentioned outright that I'm just going to mention in some closing comments is, as we talk about equity, and we've talked a lot about how moving the needle in these various ways can improve equity, but also thinking about improving equity in and of itself. And so, when we're looking at, again, I'll just give an example from, the provider perspective, like when we're looking at, say, reducing, 30-day readmissions. You could have a program that maybe on average doesn't significantly move the needle on readmissions, but decreases the differences among different, socioeconomic groups or demographic groups on readmissions. Like, could we say that that is still a success because you are moving the needle in terms of addressing some disparities? So just, I think as we think about, equity and thinking about it as something that is a goal in and of itself and not just, oh, if we move the needle in these larger things, then equity comes along, but really having a focus specifically on equity as well.
Thank you for that. Simon, do you want to go next?
Yeah, just to echo what Mina says. It's been a really interesting discussion, which I've really enjoyed. It's difficult how to get decision makers to act better in our interests. I guess, one of the things is how it's really important that we do the best possible evaluation to inform, to provide the data they want, the evidence they want, but also which reflects to everyone what those values, when they make their decision, what values they're basing those on. And we can then say if we think they're fair or not. I guess one of the other things I didn't really talk about before, but I think it's valuable actually just being able to reflect what the current value structure is imposed by the institutional arrangements in which decisions are made. So that we know, how much does healthcare spending generate at the margin? How much does public health spending generate at the margin? How much does social care and welfare spending generate at the margin? It lets us reflect as a society about whether we think, well, actually, is that how society values things? Is that a fair reflection about how we want to trade off health generated by public health and healthcare, how we trade off criminal justice and other things? I mean, useful, be able to reflect back those current values to decision makers to hopefully improve decisions moving forward.
Thank you for that. Chapin, do you want to go next?
Sure. I just want to observe we're at the 1 year mark since the world shut down, and there's been huge federal legislation. There have been huge changes in how we do work, where we work, how the healthcare system works, and we at CBO are trying to figure out how the world is going to keep surprising us, and we're relying on the folks in the research community to help us make sense of what's happened and just think about the coming years and just help us process where we've come from, where we are, and make sense of where we think things are going, because the world has changed.
Thank you for grounding us with that. Jacob, do you want to go next?
Sure. I first want to just thank everyone. This is a really amazing discussion, and I learned a lot. And I wanted to just echo the points that Mina and Sherry said about equity really is a pursuit in and of itself, and that we have a moral imperative based on our history and our contemporary practices to pursue that. Not to end on a down note, but this is a challenge. It's been a challenging time for science broadly, and social science maybe in particular. And I'm not, Dora, you posed the question of how do we convince other people to use science, and I'm not currently convinced that all people can be convinced. And so that raises complicated political questions about, well, who do we have to kind of move, that I don't really have the strategy for. That's way above my pay grade. But building resilience in the scientific community and building belief in the scientific community is a long-term goal and something that we should all work for. And I agree with Sherry that we should raise taxes dramatically.
I didn't say we should. I just said it would make Chapin happy.
I'm not going to endorse that.
All right.
Well,
Sherry, do you want to pick up from there?
Okay. Yeah, I mean, I guess I'm a little more, I want to end on a note of optimism. I do think that social science, that research can contribute to doing a better job here, because I think we can sometimes, not always, not all the time, certainly separate what it is we want to do and how it is we want to do it. And it's hard to use science to persuade people of what it is we want to do. I think Simon was making that point as well. That's a decision of priorities, and I'm not going to be able to persuade people who have very different sense of priorities than I do based on my research that they should change what they're doing. They just don't think that the things that I think are as important as I think they are. But it often does happen that there are policymakers who want to do the right thing in some area, and they're not exactly sure how they should do it. And this is actually a place where something like CBO, maybe done outside of government, could be the most effective. So which housing policies are actually the ones that are going to work? Should we be focusing on housing, or should we be focusing on food stamps? I think there's lots and lots of room in that game for us to be actually learning things and telling them to policymakers who could do something with them. It's not going to separate, I learned my years in the Humphrey Building, if I didn't know before, taught me that, good economics and good evaluation research is not the only thing that can or should drive policy. It can't be. But it can contribute to when there's a decision to be made that you can say, try it this way, this will work better.
Thank you for that. All right, the final minute, Rachel, or the final word to you.
First, want to check if you can hear me.
Yeah, it's
okay.
Back.
Great. I was thinking, I really appreciate Sherry's last points and largely concur with those. From the standpoint of what the research community itself can do, I would advocate that as we think about how to translate our messages and our findings to be of value to those creating and implementing policy, that we also look internally as to what those messages are and what assumptions are implicit and unspoken in the way we craft our messages and do our science. And that's not necessarily an evidence-based recommendation, but I do think, considering as we look historically at all the science that has been marginalized in one context or another, we have an opportunity to put a different lens on our own science and our own thinking going forward, and how we use that new lens to translate to action.
Thank you. Thank you very much to all of the panelists. This has just been a brilliant conversation. We so appreciate your taking time out of your schedule to share your insights and suggestions and knowledge for me and all of the viewers. This has just been tremendously helpful. We are